Sir, you can start the session. The room is open for
Yeah.
something.
Right, thank you. I'll start in 1 minute's time.
Okay.
This one. Okay. Good evening to all of you. As usual, we'll start with 2-3 short cases first. Just 1 minute. Can you see my screen?
Yes.
Right. So in fact, this patient I had shown you earlier, but this time I brought with a different purpose. This is a 28-year-old female. Her complaint started as inability to elevate or extend her left thumb while she was doing her dance practice 3 days back. She also noticed that she could not pleat the hair of her daughter when she was trying to do the hairdressing. There is no pain, no other complaint. No paresthesia from the history. So only problem was inability to extend or elevate her left thumb. No other complaints. This is a video of the patient. No wasting anywhere. Tone was normal. Deltoid, biceps all normal. The section was normal bilaterally. Finger extensors were normal. But look at the extensor of the thumb on the right side is normal. Both extensor polys longus and brevis. But on the left side, she is unable to extend at all. He could not extend the extensor polys longus as well as brevis is weak. So also the longus is also weak. And flexor polys longus is normal on the right side. So also normal on the left side.
Very good.
And flexor polys brevis is also normal bilaterally.
Very good.
Abductor polys longus was normal on the right side. It's also normal on the left side. Longus as well as brevis is also normal. And the finger abductors were all normal bilaterally. That is normal. Normal power. The intro-shape is normal. The opponents was normal bilaterally. No problem. No one for the opponents. Performance sign was negative. The palmar intro-shape were normal. So look at the left thumb, it has dropped down, but she's inability, it can elevate a little bit. She is going down on the left side because of the weakness of the left thumb. There's a thumb drop. Okay. The rest of the examination is no finger nose incoordination. I think lower limb power was normal. The reflexes are all normal. Finger flexion normally elicited. Knee jerk and ankle jerk normal. Come to the sensory. Plantar flexor It was to decrease sensation in the web space between the thumb and index. That area she tells is little less compared to the right side. That's normal. On the dorsal aspect, it is decreased on the left side between the web space between the. There she's telling little decreased. That area. Other areas are not. That's the area she's pointing out where there was a numbness. Vibration sensors normal bilaterally. Joint sense normal. So, on examination, there is weakness of left extensor hallucis longus and brevis. There is left thumb drop due to that thing. Rest of the examination was within normal limits. DTR upper limbs brisk, normal in the lower limb, plantar indefinite. Sensory system all normal except for the numbness or the small area of the web space between the thumb and the index finger. So, where is your localization in this patient? Weakness of only extensor pollicis longus and extensor pollicis brevis.
Partial radial nerve.
Yes, partial radial nerve because you're soft spot in numbness. Where could be the radial nerve lesion in this patient?
Sir, in the distal part of the spinal groove, just.
Okay, but why other muscles are spared in this patient?
Can it occur in partial involvement of the nerve, like?
Yeah, that's true. That may be what you said is correct. Partial involvement of radial nerve. So, what could be the etiology in such patients?
Brachial plexitis.
Yeah, most likely neurology. So this I had told you before. Sometimes brachial plexitis can only. Last week I showed a case only the flexor pollicis longus is weak. No other muscle was affected brachial plexitis. Just like that, this lady also got only extensor. Only this time the extensors are affected. It is unlikely to be supinatus syndrome. Big supinatus syndrome affects the anterolateral nerve, posterior nerve, and the supraclavian should be spared. Here, supraclavian is also affected. So it is not a supinatus syndrome. The lesion is proximal to that. So as you all said correctly, it's a partial radial nerve involvement. That's the site of lesion. Okay. Because, right. Now, NCS was done. That showed that there is a conduction block in the radial nerve above the spiral groove. Or above, not elbow, just above the elbow, there is a conduction block. And that was causing is selective involvement of the extensor hallucis longus and weak brevis. Sensations were all normal, FF normal, and she has got total recovery with a short course of steroid, total recovery. And I think I will skip all these things. This again, I want to highlight this, the 2-3 sentences from literature. Inflammation seldom occurs in brachial plexus itself, but mostly in distal branches. For this reason, the term brachial plexitis has been largely abandoned, with authors proposing more accurate descriptions of the underlying pathology, such as mononeuropathy or multiplex. In rare cases, also the nerves which are not related to the brachial plexus can be affected, such as phrenic nerve, cranial nerves, or even lumbosacral plexus. This is the patient, and see the repeat conduction. There, the conduction block has totally disappeared. Okay, this is the prelude to the case which I am going to show now. A similar case. Let us say this particular story of this 49-year-old female. She gave history of pain in the left wrist and forearm for the last 1 week. 3 days back, while she was cutting vegetable, she noticed dropping of her left thumb while she was holding an onion with his left hand. No other complaint, no sensory complaint, no root pain. So this is the examination finding. It's a short case. The triceps is normal. Brachioradial is normal. There is a normal side. Wrist extension is normal. It's also normal. Finger extension is normal. Finger flex is normal. Normal power. That is a right side normal. Flexor pollicis brevis normal. Longest also is weak. Normal. Now look at the extensor pollicis longest on the left side. It is weak. It's weak now. Pollicis brevis normal on the right side. Weak on the left side. No movement at all. Not at all moving. On the other hand, the carpometa movement is normal. And the abductor pollicis is also normal. I'll show the lid subsequently. The extensor pollicis is the one. That's also weak. This is subductor pollicis longest normal in the right side. So also normal in the left side. And abductor pollicis brevis also normal. There is brevis again normal. But however, this patient's sensations were normal on both sides. So on examination, there was weakness of extension to the distal and proximal phalanx of the left thumb. Normal power of the carpo metacarpal phalange joint of the thumb. Sensations all normal. TTR normal. So what is the diagnosis?
Posterior interosseous.
Okay, posterior interosseous, because the sensations are staying. Perfectly right. But why only those two muscles are affected?
The same thing like before, fascicular vulnerability.
Yeah, right. Vascular vulnerability is a problem. But she complains of pain in the wrist region. Okay, let us see. So what test you need now?
NCS followed by wrist MRI.
Right. The patient came with the NCS study that is normal.
MRI around the wrist joint, sir.
For what?
Sir, any inflammatory pathology or entrapment that might occur?
So for that, you have to look for a wrist is that the one record image you have the forearm, no? Entrapment means occurs in the case of posterior entrapment, that is supinated septum occurs in the artery of force, that is the arch of force, that is in the supinated arch, that is the upper forearm. Okay, so can be a stroke in this patient. He came with only no sensory complaint, only motor, acute onset.
But there is gross weakness of the muscle, sir.
Yeah, there is a gross weakness is there of the thumb.
But then the whole thumb will be affected, not just
Yeah, right. Usually it should affect all the muscles of the thumb should be affected. But rarely you can have a cortical wrist drop, thing can occur. But it should affect the other fingers also. But that possibility can be totally ruled. Anyway, the patient came with an MRI by himself. I did not bother about that. This is the MRI of the patient that is normal. When the picture is feeling poor because that is taken from the monitor. The diffusion is normal, and this is the flare is normal. Interesting is tendon rupture. Okay, what do you want now?
Extensor.
Pardon?
Extensor compartment tendinitis, selective tendinitis.
Very good. Okay, let us see. So see this video now. This see, I tried to press on the tendon. See that it was complaining of there's an area of tenderness. Again, also on the middle of the dorsum of the that's area is complaining of tenderness. So now what is likely diagnosis?
deep
But that
pressure.
won't cause so much of weakness, no, sir. In spite of pain, we have seen a lot of decurrence disease without any
Well,
weakness.
absolutely, absolutely. Pain is dominant. So what should have happened now?
The weakness would have led to tendinitis.
Yeah. Weakness should have left tendinitis. That is a real question.
Or
Weakness leading to
tendinitis would have caused.
Might have received a steroid injection, some tendon rupture kind of thing.
Sir,
the steroid was not given.
tendon rupture.
Yeah, that's correct. So this is a tendon. Tenosynovitis is one cause of tendon rupture. Now look at we took an MRI of the wrist. I'll show the wrist. I think it'll be different. And this is the area of thickened, enhancing the proximal part of the extensor pollicis tendon. That is the distal part. Normally the tendon should appear dark. It is that is a distal part which is normal, which is seen there. There is a normal one. Then it comes in between. There is nothing. There is edematous portion. Then there is a gap. Then the other proximal end showing the hyperintense retracted tendon.
It's not ruptured, no?
It is ruptured. The in between there is no tendon. I'll show the picture once again. This is the torn end of the extensor pollicis longus tendon, proximal retracted end, thickened and hyperintense. Normally the tendon should be dark, like as shown above. The inflamed, retracted proximal end.
But
Then
there is continuity, no, sir?
There is no continuity. Actually, what happens means the extensor pollicis tendon goes to the dorsal aspect of the wrist, goes across the joint, and then reaches the dorsal aspect of this thing. Unlike the other tendon, takes a deviation from the middle thing. I'll show it subsequent film. I'll show that. So this is a proximal retracted end. That is the distal retracted end with fluid. So that fluid is the one which is hypovenous. Okay, I'll show the other picture. That is a normal healthy tendon which is seen as a dark one. See the anatomy there is now. So this is anatomical compartment. See, this is the lateral most compartment, first compartment, abductor pollicis longus, extensor pollicis brevis. Then the extensor carpi radialis and longus and brevis. Then this is the area of the extensor pollicis longus. There is a tube. This tubercle is called that tube. What do you call the tubercle? I'll tell you the tubercle. Just forget the name. So, and see what is happening to our patient. This is the first compartment. This is the second compartment. Third compartment, the tendon is not seen. This is the third compartment where the extensor pollicis longus is situated. That's called Lister's tubercle. Lister's tubercle.
Is it still seen, sir? One dark thing is there?
No, that's not the tendon. The dark one is the tendon. That's a normal tendon. That's a normal tendon. I'll show I'll show the one more film. That is the area where the tendon is not seen. I'll show once again. This is the picture there. That is the area where the tendon is not seen. It's seen as, or the darkness has disappeared, inflamed tendon, part of it. But the area which is broken is in between the connection between the dorsal aspect and to the dorsal of the thumb. That is the Lister's tubercle. That is a landmark for the extensor pollicis longus tendon. And you can also make it here. This is a sagittal cut. That is a torn end of the tendon which you can see proximally hyperintense. And subsequently, this thing, see the other tendon, they are going dark forward, but this tendon is broken in between. And you can see the distal part is again hyperindent, the retracted one. That's again normal tendon. That is a distal end. The proximal
Why was the
retracted
MRI done, sir?
I'll show this until here. This is the proximal retracted end of the extensor pollicis longus tendon. And this is the distal part which is seen there. And that is the normal tendon. Tendon should be like this. So this portion, the proximal portion here, in between this one and this one, the tendon is not seen. Now, MRI was done because suspecting a tendon rupture itself. That was my clinical diagnosis because of the tenderness on the dorsum and the The only muscle lost is these two muscles. The previous patient I was lucky that patient had some sensory symptom in that area. Moreover, if you look at this particular person and the lady, there is absolutely no movement of the thumb at all. On the previous lady had some movement possible. That does not indicate a tendon rupture, means there will not be any movement at all. That is another clue. So this is tenosynovitis tendon rupture. Just a few words about it. Tenosynovitis or inflammation of the tendon sheath can lead to rupture of the extensor pollicis longus tendon, which is responsible for extending the thumb. This can cause pain, weakness, and difficulty in extending the thumb. Causes rheumatoid arthritis, distal radial fracture, repetitive motions, steroid injections, as somebody has pointed out, and tenosynovitis. And look for swelling and tenderness around the Lister's tubercle. That is the diagnostic clue for the tendon rupture.
Was there EPB spay?
No, in extensor pollicis, it also is affected partially. Main affection was extensor pollicis longus.
So what was the sequence of the MRI with fat suppressed, with contrast or non-contrast?
It's non-contrast one. Non-contrast one. Then that bright thing is the what is in the still sequences. It's not a contrast. Because the edema it becomes hyper intense.
Okay.
Okay, any questions? Okay. Shall I go to the next one?
Yes.
Okay. This is a story of a 79-year-old college professor. History of slowness in walking for the last 3 years. In fact, I had seen him first about 2.5 years back. I thought he may be having early Parkinsonism because he was only slow in walking. However, there was no definite features other than the slow gait. So I was put Corey Parkinsonism, very early Parkinson plus syndrome. I had put him on Syndopa plus in low dose. He claimed mild improvement in gait on follow-up after 2 months. However, his walking became slightly worse subsequently, became more slow. So re-examination after 3 months showed that he had some abnormal movements in the tongue. Then I called him, this is not simple Parkinson or something else is there, I do not know what you are having. So I called him for admission for a detailed evaluation. But unfortunately, he did not turn up. He came for re-evaluation after 2 years. His present complaints, apart from the slowness in walking, were my wife has noticed involuntary movements in the neck, shoulder, and face for the last 2 years. Excessive sleepiness during the daytime and restless movement during sleep. He dozes off while talking, and on awakening after a few minutes, he makes grunting noises and sometimes remains confused with prominent visual hallucination. Such sleep episodes occur about 10 to 15 per day. For the last 1.5 years, his wife has noticed that during sleep, he shows actions as if he's taking classes for his students in the college, or sometimes as if he's driving his car. He never did show a violent behavior during sleep, did not kick his wife and all. Patient was also noticed to have imbalance while walking, mild imbalance while walking. There was excessive snoring for the last 2 years. So present complaint, involuntary movement of the neck, which I am going to show now. Excessive sleepiness. He dozes off while walking. And on awakening after a few minutes, he makes grunting. Somebody is interrupting, please, can they? Yeah. Sometimes he remains confused. Prominent visual hallucinations. Such sleep episodes occur about 10 to 15 per day. For the last 1.5 years, his wife has noticed that during sleep, he shows actions as if he is taking classes for his students, sometimes as if he is driving a car. He has also noticed impaired memory for the last 2 to 3 months. That's on reading question. So this is the video of the patient. Look at the arm movement. He has got jetty movements like this. Neck also goes to side sometimes. He makes the fungal movement like that. Neck also is having both this way and that way, restless on the feet. Sometimes dozes off and then wakes up like that with the jerkiness of the trunk. Make some noises like that. Grunting noises like that. Okay, so the next part of the same thing only take a close-up view. Little more some other additional features also.
Last വികാരം പറഞ്ഞ
It also saw. Suddenly Jackson come out. So he examined the tongue showed this kind of a dyskinetic movements. I'll show that once again. And in postural tremor, rest of the granules were normal, bilateral mild postural. Rest of the examination, motor examination. Lower lip tone power normal. Reflexes are all normal. Plantar angle jerk is absent. No, it's just elicitable. Plantar was flexion. Sensory examination also normal.
അറിയുന്നുണ്ടല്ലോ ഒരു വൈബ്രേഷൻ ഇതറിയാം ഇതും അറിയാമല്ലോ
This is the way he walked. Walked slow but exaggerated arm swing was there. So on examination, high malfunctions impaired recent memory. No definite executive dysfunction, but he was a little slow in grasping things, meaning the questions with customary speed. The rest of the eye malfunctions were normal. Cranial nerves all normal except for the lingual dyskinesia. Motor patient shows irregular, non-repetitive jerky movements to the face, neck, and upper and lower limbs. Tone power was normal, DTR normal, sense system normal. Had a clumsy gait with bent posture of the trunk and increased arm swing. Patient goes into sleep even in the consulting room and awakens after 3 to 4 minutes with sudden jerkiness of the limbs and neck. So, what do you think is the likely possibility in this patient?
Iglon
or
5.
MSA?
Total duration 2.5 years. More
Iglon
than
or
2.5
MSA?
Igilon 5 disease or synucleinopathy like MSA.
Okay. Which MS? What MS?
Because the neck movements and sleep again can be affected in MSA.
Yeah, but yes, could mean what is involuntary movement is more like a choric movement. No? Choric movement. Okay. See, this is similar. Look at the involuntary movement for this particular patient here. Same as this patient, our patient.
I can't say I'm a phone ticket.
Is it choreo or myoclonus?
So mainly choreo is definitely there. For the more like a man. Cannot suppress characteristic involuntary movement. It is a combination of both. So what test you want?
Iglon antibody.
Iglon.
So MRA was initially was done at this because of the movement was not clear. Dorsally null. This is a diffusion. What are the tests? EEG was done normal. Autoimmune surveillance panel negative. Then a paraneoplastic antibody profile was also done. This is the antibody which was done. They're not done from outside. So what else you want now? In fact, because of this involved endocrinology consultation was sought. So here do is a Dotanox scan. I did not know what the scan was. It is also
for parathyroid.
in fact they diagnosed neuroendocrine tumors. It is also known as GA68 Dotanox scan is a medical imaging procedure that helps diagnose neuroendocrine tumors. So in fact that was done, he had a neuroendocrine tumor. The duodenum. Okay, that was ligated. So what else you want now? Even after that remains like that. Could it be a paraneoplastic phenomenon?
Could be.
Okay, anything else you want?
Calcium. What was the calcium, sir?
Calcium is no. Calcium parathyroid now.
Gastrin.
That I do not know much about endocrinology, so
Sir, Igilon was it there in the autoimmune panel? Igilon was not there, I think.
right, correct. So now I want to know what is this symptom which I have told before.
Chorea without cognitive impairment is one of the presentations of Iglon 5 disease.
Right. Let us see. I want to know the symptomatology. For the last 1.5 years, his wife has noticed that during sleep, he shows actions as if he's taking classes for his students. And sometimes as if he is driving his car. What is this?
Agorapenic excitata, sir. I don't know how to spell it, sir, but
This is 100% correct. This is called agrypnia excitata. That is classically seen in Iglon 5 as well as Casper 2 antibody disease. And the other name is actually, this is called, as you all said, is Iglon 5 is strongly positive both in TB as well as cell-based assay. This chorionic stupor, or as I said, as already said, agrypnia excitata, is a distinct feature of autoimmune encephalitis where patients perform simple gestures mimicking daily activities. So that
RBD, no?
No,
RBD.
No, this agrypnia excitata is not synonymous with Iglon 5. This is a phenomenon which is seen in sleep. They can have associated RBD and hypersomnia. They're all part of that thing. And this sleep enactment of this kind of a thing is a classical of agrypnia excitata. That's a specific condition. But the term itself, the condition is the particular, this phenomena is called oniric stupor. Okay, anyway, that is Iglon 5. Symptoms appear in different combinations and time periods. As this is the peculiarity of this one. Initially, when I thought he had only slowness in walking. Subsequently, the involuntary movements appeared. Then subsequently, his sleep disturbances started. So that is a peculiarity Iglon 5 because the symptomatology differs at different times. Symptoms may appear in different combinations and time periods, and the disease onset and throughout the disease course of the disease, leading to a different clinical subtype. It may be in the form of sleep disorder with abnormal movements and behaviors, insomnia, excessive daytime sleepiness, sleep disordered breathing in any combination. Or a bulbar syndrome involving dysphagia, dysarthria, respiratory failure, and central hypoventilation. Or a syndrome resembling PSP with gait instability, falls, and gaze palsy. So unlike classical PSP, here in Involved 5 PSP, the downward gaze is not affected. It is upward gaze is involved first. They can present cognitive decline with the dementia, often exhibiting chorea, leading in some instances to syndrome reminiscent of Huntington's disease. A fifth subtype has also been identified recently. So I think I'll skip all these things. This all of you know. Right, I think I'll skip this thing. Now I'll show another case. This again I've shown something back. This again another case of Iglon 5. This is a 54-year-old. So I will just show the different types of presentation of Iglon 5. His complaint started 8 months back as difficulty in speaking in the form of low volume of speech. After speaking for some time, his voice used to get stuck and interrupted, like a spasmodic dysphonia. He has to exert more force to speak after some time. Wife noticed some involuntary twitching movements in the neck for the last 2 months. It was also noticed to keep his neck bent to the right side and walk with trunk tilted to the right. It's a short video, only showing the positive findings. Look at this. I'll show the classical spasmodic twitch once again. It becomes strangulated and becomes very low volume. This is the involuntary movement he had. The mychemic like movements in the neck. And look at the way he walks. He walks with a bent neck to one side. No typical pizza. Neck is bent, shoulder is also drooped to one side. Some of you may remembering that this case I presented some time back. He had spasmodic dysphonia. He is found to have undulating slow twitching movements of the larynx and anterior neck muscles, lateral collis and lateral leverage that run to the right side. And look at this patient. This again from literature. He has also got something similar to that. He has got some Parkinsonian features as well as tilt to the run to one side. Just like our patient. He's also not typical PISA. Head is tilted to one side. The shoulder is also drooping to one side, just like our patient. This also literature. This is from literature. A patient of Iglon 5. So just like let's show the last part of this one, the way he walking. See the same type of head tilt and everything to one side.
What happened to the other patient's neurology?
This one?
No, that patient's that PET scan or something had come as positive, no?
Which patient? In the
First
previous
patient.
one?
First patient, your first patient.
He is undergoing treatment only.
No, he's some PET scan or something showed something in the duodenum, no?
Yeah, that was a neuroendocrine tumor.
Nothing related to this.
Nothing related to this. That was excised, but it continued to have symptoms. Now, this is second case, again strongly positive. And this patient improved remarkably, totally improved. Everything subsided, but over a period of 6 months. Initially, I put him on methylprednisolone, then followed by rituximab. After 3-4 months, he became totally asymptomatic. Some people take long time to recover. Some people recover fast. You do not know which patient. Okay, that's about that case. So remember these 2-3 cardinal symptoms of sleep-related enactment behavior is typical of Iglon 5 or Casper 2. And of course, there are other features. You can present various types of person like chorea, Parkinsonism, can present with sleep disorders, hypersomnia, involuntary movements. They can present stridor, spasmodic dysphonia. Many all types of presentations are known.
So,
Yeah,
what is
any
the clue for
questions?
Iglon 5, sir, in the second case, sir, with spasmodic dysphonia? No, no. What is the clue for Iglon, sir?
It's spasmodic dysphonia, plus some Parkinsonian features like tilting of the tongue to one side.
That
And
can
some
be idiopathic spasmodic dysphonia also, no, sir? What is the clue to consider Iglon 5?
it is not a pure spasmodic dysphonia. You had in addition other features, no? And usually in adult onset focal dystonia, only spasmodic dysphonia will be there. There were other features of tilting on the tongue, involuntary movement, other involuntary movement will not be there. That is why I suspected this one. Some secondary cause of spasmodic dysphonia in an older age. Because other conditions are all present, except movement disorder, present little more younger age group. These things which present in older age group. Shall I go to the next case? Any more questions in this case?
Sir, how is this patient doing now, sir, with steroids?
The second case I know, it is improved remarkably. The first case is undergoing treatment only. It's not just diagnosed only very recent. I don't have the follow-up of the patient. Okay, shall I go to the next case?
Yes, sir.
Okay. The story of a 65-year-old diabetic lady is old case of CKD. 2 days after shunt placement in the elbow, patient noticed numbness, edema, and weakness of the left hand. Just 1 minute. Bichu, ഞാനൊരു 2 മിനിറ്റ് 5 മിനിറ്റ് വിളിച്ചാൽ മതി. ഞാൻ കോൺഫറൻസിലാണ്, മീറ്റിംഗിലാണ്. 2 days after the shunt placement in the elbow, patient noticed numbness, edema, and weakness of the left hand. Let us see the condition. His brachioradial power is normal. Price is also normal. He's got a pain, that is why she is called 0 for the wrist section. 0 for the wrist flexion. More than 0.
എൻ്റെ കൈ വെച്ചിട്ട് ഇങ്ങനെ വിടത്താൻ നോക്കിക്കോ ഇങ്ങനെ.
He could not abduct or adduct the fingers.
മതി കഴിഞ്ഞ ഡയബറ്റിക് ആണല്ലേ.
The reflexes are all down on that's normal side, on the clip elicitable, left side it is absent. So triceps is absent bilaterally. Just elicitable. Examine the sensory.
ഈ കുത്തൊന്നും അറിയാം. ഇപ്പോഴോ അറിയാം.
Is lost on the thumb.
അറിയാവോ? ഇതോ
lost on the dorsal aspect of the thumb.
ഇനി അറിയുമ്പോ അമ്മ പറയണേ, അറിഞ്ഞ ഓട്ടം പറയണേ.
She will tell you when she's able to feel the pain.
അറിഞ്ഞ ഓടം പറയണേ.
There she said that's area she is feeling pain. Again she will tell you the site where the pain is appreciating.
അറിയാം.
That's area.
ഇത് അറിയാവോ?
Over the little finger she is able to feel.
അറിയാവോ?
She is able to feel over the little finger.
കഴിഞ്ഞ് ഇപ്പൊ അറിയാവോ?
Or not over the thumb.
ഇതറിയാം.
Little finger she is able to feel.
അറിയാവോ അമ്മയ്ക്ക്? ഇല്ല.
Not on the palmar aspect, the thumb also not able to feel.
ഇവിടെ അറിയാം.
But she is able to feel on the middle part.
ഇല്ല.
Vibration is also lost on the thumb.
ഇപ്പോഴോ?
Felt on the little finger. Okay. Findings now. Findings are confined to the left upper limb, edema on the left hand. Grade 0 power of wrist flexes, wrist extensions, all finger and thumb flexes and extensions, and all small muscles of the left hand. DTR, left supinary checkerpiece, sluggish, triceps just elicitable. Decreased pain over the palmar and dorsal aspect of the left hand. and left hand of all the fingers except the little finger. On the little finger alone, on the dorsal aspect, the palmar aspect, she is able to feel the sensation. She is able to feel the vibration, little finger. All of the fingers, she is not able to feel the pain or touch or the vibration. And sensory loss goes up to the middle of the forearm. Sensory loss extends up to the mid dorsum of the left upper limb, up to the middle of the lateral forearm. Lateral forearm also is affected. Normal sensation over the dorsal and palmar aspect of the little finger. Vibration is impaired over the left thumb, middle finger, and preserved over the left little finger. So where is the localization of this? Biceps normal, deltoid normal, triceps normal. Brachioradial is normal. Other zero power.
Lower cord and medial cord.
Lower cord.
Middle cord.
Middle cord, then how to explain the sparing of the triceps muscle in this patient?
There can be a selective involvement.
Yeah, but selective involvement, okay. Zero power of the finger, all the muscles with other things, totally normal. Partial involvement, okay. It has also got a sensory loss, not fitting with any pattern at all. Except to the dorsum, it is lost. The medial lateral aspect also it is lost. Very funny finding, no? You cannot explain by a root, not explain by a trunk, not explain by this thing. Then how to explain these things? Because he has got a sensory loss in the halfway through the musculocutaneous nerve, but other muscle supply musculocutaneous nerve is preserved. Other area of the sensory is preserved.
It could be multiple nerves with partial affection.
Yeah, multiple nerves partial affection. So what can be? It's only confining to the left up. So what could be the reason?
Neuralgic again.
Pardon?
Neuralgic ametrophy.
Okay, but do you get this thing like that? It's usually usually got a predominantly motor involvement. Okay.
Or a Lewis-Sumner syndrome.
But only confined left upper limb.
Lewis-Sumner syndrome, focal.
But only confined to focal. Theoretically, you're all right. But are you very happy to diagnose with this kind of all?
Compartment syndrome, since he has swelling and pain.
Yeah, but that's a good point. But the problem is which compartment? He's got involvement ulnar, median, radial, musculocutaneous part, lateral part, medial antebrachial cutaneous nerve also is affected. It is as if somebody has tied around a tourniquet around the forearm and strangulated all the nerves distal to that. Is that correct? This can occur. Suppose I'm strangulate my forearm like this, tightly down, all nerves are compromised. Distal to that, proximal to the everything now.
Yes.
How to explain normal ulnar sensory, sir?
That is less affected. When the ulnar muscles are weak, zero. Only the sensory is relatively spared. That's all. Not totally spared.
So usually we say in compartment syndrome, the sensory is the first to get affected, sir.
It's not a compartment syndrome at all. There's no question of a compartment syndrome here.
Posture aspect is also important.
Sir, is it painful? Ischemic neuropathy is possible? Ischemic neuropathy?
Right. Right. Let us see. So what is it like this? What test you need now? I'll show the NCA study. Okay. So let's see the NCA study. Okay, before an NCA study, she has got, this is right median, you can put that. Left median, no potential. That's left one. Right is a part there. Left ulnar, again, grossly decreased, but compared to the median now, it is better. That's right. Left radial, again, no potential. Left deltoid and muscular is also partially affected, but not affected. But look at the sensory. Left median not obtained. Left ulnar not obtained. Left radial not obtained. Ankle antebrachial not obtained. Left medial is also not obtained. And F5, of course, because potential is not obtained, you cannot get the F5 also. So where is the likely, sir? What is the likely diagnosis?
Was the surgery done under blocks, sir? Like they do a multiple nerve blocks?
Is it
No,
this thing, the shunt?
Yeah.
yes, that is why I showed you the slide now. The
Ischemic.
first slide. Yeah, 2 days after the shunt placement in the elbow. This I am seeing the third case now following the shunt. Unless you close the shunt and place it somewhere else, your hand will go. You cannot recover, you will not occur. It should be done immediately. This is one of the complications of shunt placement. Yeah, what happened mean the blood flow is cut off, so it is not respecting to any particular nerve. Distal to that, the nerve vasa nervorum is, it will not fit in with the particular nerve pattern involved. The branch where it is ischemic, that will be affected. So I'll tell you, this condition is called as ischemic monomelic. I'll show that condition. It's called ischemic monomelic neuropathy. Vascular access non-diabetics. There are 2 to 3 sentences. Ischemic monomelic neuropathy is a rare complication following an arteriovenous fistula surgery that is characterized by acute onset of pain, weakness, and sensory changes without critical ischemia. This is due to the decreased distal arterial flow caused by the shunting from the artery to the vein after vascular access surgery, resulting in underfilling of the vasa nervorum, leading to multiple axonal losses involving the sensory and motor nerves produced after acute atrial occlusion or reduced blood protein extremity. This affects multiple distal nerves and extremity involving sensory motor branches. In general, sensory complaints are more prominent than the motor. Symptoms occur along the distribution of radial, ulnar, and median nerve, resulting in poor reception nerve. Same thing. And the forearm muscles may be relatively spared compared to the intrinsic hand muscles, resulting in profound loss of handling. The radial may be partially, remember the pulse may be felt. You may feel the pulse may be normal. Because it is affecting the ischemia is causing the vasa nervorum. So any questions in this case?
There is
So
treatment.
Yeah, treatment is immediately reverse the shunt. You close the shunt and put it somewhere else. Or do it on the other upper limb. Or in the neck, somewhere else you have to do. Because the blood is diverted through the vein. The nerves are not getting blood supply.
They will recover usually.
They recover provided they do it immediately. They recover. The previous 2 cases which good.
So the nerves are not stimulatable in NCS, like, sir?
Yeah, correct. Because nerves are it's not functional. Because the nerve, it's like a nerve palsy only.
That means that the nerve has went for axonal changes, sir. Then how we might explain the recovery, sir? How can
No,
we
that
have?
that what your point is correct. But it's only that does not mean the nerve cannot regenerate. Even axon loss, the nerve can regenerate.
Yes, sir.
When the causative factor is removed, it can.
There may be demyelination also.
Usually it is an axon loss which is seen here because this NCS picture also like a axonal loss. Amplitude is not very low.
So is it because of the edema the amplitudes are reduced?
No, but it's got clinical weakness also. Not only sensory is also affected, no? The sensory part is also affected. The medial anterior brachial cutaneous, there is no edema, there's still that. Clinically also weakness is there. Okay. Any questions? Shall I go to the next case or last case? All are short cases too.
Yes.
Okay. This is a story of a 16-year-old girl. This 16-year-old mentally challenged girl had been under treatment for resistant complex partial seizures since childhood. The type of seizure was complex partial seizure with secondary generalization. So I tried for resistant seizure, tried various permutations and combinations of anti-epileptic drugs to get the seizure under control. So ultimately, I could manage to get seizures relatively under control with a combination of carbamazepine, clobazam, and phenobarbital, except for occasional mild attacks once in 3-4 months. The thing is that about 1 month back, she was brought with recurrence of attacks of different nature, not the habitual seizures. Luckily for me, she developed one such attack while she was waiting outside my consulting room so that I could see that. And this is where she's entering my room with that abnormal movement. This is how she behaved.
ഇതുപോലെയാണോ സാധാരണ തിരിച്ചു വരാറ്? ഇതുപോലെയാണോ സാധാരണ വരാറ്?
ഇപ്പടിയും വരാൻ ഇല്ലാമ വെട്ട് ரெண்டு கையும் காலம் ஒரு காந்த கை ஒரு இப்படி வந்து இருந்தாப்புல தான் வெட்டு வரும்.
ഇതെഴുതും.
Okay, what do you think about the movements now?
Looks like a hemiclonic seizure, sir. Hemi-distribution.
Yeah. Is it like a seizure?
No, sir. It's like a movement disorder. More
yeah,
of movement
disorder. Yeah.
Probably.
Yeah, could be that. But she was on carbamazepine, but only more on one side. Carbamazepine, phenobarbital, and clobazam.
Maybe as she has lesion on the left side, which would is the right side, predisposed the right side for the.
There's a possibility. So in fact, I thought maybe functional superiority. Many times, general seizure can be associated with functional seizure also. So I thought it could be functional because episode disappeared and diverting attention. But I was not very sure. So I was considering pseudo seizure in addition to original genuine seizure. So the patient attacks were entirely different from the previous semiology of the seizures. So I had given her mild anxiolytics and the attack subsided. So I was happy. After about 2-3 months, she came to me to get clearance for cataract surgery. The story was that she developed defective vision and went to the ophthalmologist, and cataract was found out as the cause of defective vision and was advised cataract surgery.
Calcium?
Yes. That is the time when the thing struck me that the patient has hypocalcemia. She had no thyroidectomy, nothing. Because, see, the other, as you said correctly, the involuntary movements are choreothetic and dystonic movements. But it is quite bizarre, not like a typical show the movement. See, it's some varying for time. It is not something like a jerky movement. It's like a choreothetic, but see, then she's holding like that. Sometimes she's bent forward the trunk. Retrospectively thinking, all he said is correct. He's got a dystonic or a theoretic movement. That I'm a little doubtful. This kind of a behavior also was a little doubtful for me. So what test you need? So it should send an MRI and say this is MRI film. Diffusion. This is the T2. There are many findings in this patient. Have a close watch on the MRI. This is the coronal T2. This is the flare. The hyperdensity in the dentate nucleus, basal ganglia, not thalamus, putamen and caudate nucleus.
Posterior aspect of thalamus also.
Yeah. Just to see once again, let me see. The thalamus is largely spared. Subcortical white matter is affected. This is that SWI. Here is the SW sequence. So what is the diagnosis now?
Can be
Hypocalcemia. Fast disease.
Fast disease is occurring in older age group. This patient had seizures to start with for many years, and then developing cataract.
Hypoparathyroidism.
Hypoparathyroidism. Is it primary or secondary? She never had any. So what is the clue?
Sir, hyperostosis
childhood.
of the calvarium.
Ah, that's the thing. Very good. See, I'll show the one finding. See, look at the thickness of the skull. See the skull thickness? Grossly thick skull. See the thickness of the skull? Much more gross thick than that is seen in primary hypoparathyroidism. So I was not knowing this thing. My radiologist told me this is one typical finding of primary hypoparathyroidism. I'll show the CT. That sheet will show much more clearly. Here again, look at the SWI. See the thickness of the skull. Then you have to see the CT of this patient. Thick base of the skull and calcification in the dentate as well as the subcortical white matter cerebellum. Also the basal ganglia, subcortical white matter. And see the skull thickness. I'll
Can
show
she
you
improve with calcium?
Yeah, I'll come to that. I'll come to that. Then, so this is the first time I was diagnosed because I had fears since I had seizures childhood, never thought it could be hypocalcemia. So I never estimated calcium before. This time after seeing this, calcium was, I'll show that, only 3. Before that, see the abnormal findings here. The bone is so much thick, poor adhesion, dental hypoplasia. Look at the skull wall thickness. It'll be amazingly thick. See the bone density, something like eroding, like an opposite hypoparathyroidism, like thing. Hypostolytic areas. and sees thickness of the skull. That's this. So calcium was 3, PTH was low. It's a primary hypoparathyroidism. Why it is primary? Because of this abnormal, this kind of a poor dentition or hypoplasia of the dentition, as well as the thickness of the scalp, are all favoring a primary hypoparathyroidism. So what is able to see the skull? Hypoplastic dentition and skull wall thickening. Sorry. And cranial calvarial hyperostosis. So this can occur both in the funny thing is that this calcification basal ganglia can occur both in hypoparathyroidism as well as hyperparathyroidism.
Did she have multiple endocrine neoplasia?
No,
that would usually produce, I think, hyperparathyroidism.
I do not know much about it, so I sent the patient to our endocrinologist. So she, after diagnosing, she has not come for follow. This only last week I diagnosed this thing, sent him to endocrinologist. Subsequently, she has not come for follow.
The X-ray of the hand was taken of the patient.
Actually, the hand, no, I did not take. I took the hypocalcemia, diagnosed and sent straight away sent to the endocrinologist. Let him do whatever test you want to do, pH and all things. That's all. I did not do further. Now, this is 2-3 sentences about the MRI radiographic features in primary hypoparathyroidism. They can have osteosclerosis, generalized focal osteosclerosis, dense metaphyseal bands. These are bands of increased density in the metaphyseal long bones. Skull wall thickening, as you have already seen. Diffuse idiopathic skeletal hyperostosis like changes. These changes resemble those seen in diffuse idiopathic hyperostosis, a condition characterized by ossificated spinal ligaments. And subcutaneous calcifications can also be seen. And hypoplastic dentition, it may develop a perundidal, just like our patient. So that's the story of this girl. So any questions? So many times, no resistance issue, we should have, we should examine further, look for serum calcium level, which we often do not do. If it is thyroidectomy was done, I would want to do that. Okay, any questions?
Why are the seizures partial seizures?
The previous one, that type of seizure was complex partial seizure with secondary generalization. I do not remember the exact aura now, the semiology now. But we can explain everything.
Wasn't an MRI done or a CT scan done before?
In fact, no. In fact, actually, this child is from a very poor family. They're coming from Tamil Nadu. So she was having under treatment various centers there. Invariably must have taken some investigations before. I do not remember all those things. Whether I want to see the old records, because for want of a case, I brought it just now. Because the patient has not come for follow-up and asked them to bring all the records. This is the last picture is only thing just available with me. Whether previous MRI was done, CT was done, I do not know. Because since childhood it has been there, so every time follow-up coming, so changing the anticonvulsant going on like that.
So why should she have episodic symptoms, sir? That is like hemidystonia, hemichorea. Why should she have episodic like that, sir? Because
Always
the
it is
pathology.
like that. No, that is one point. There are many paroxysmal movement disorders. If you look at that, for example, hypocalcemia, even cerebral palsies, Wilson disease, all these movement disorders, even though the disease is static or progressing, the movement disorders are episodic. Why it comes at certain times and we do not. Just like Wilson disease, for example. Disease is there, but the movement disorder is only episodic.
Good that she developed cataract.
Yeah, correct. If we had not developed cataract, I would have suspected. I should have suspected look at the involuntary movement. But I thought for many years she has been having genuine seizures. Now why this kind of thing occurring now? But I never suspected.
The way she was catching her right upper limb with the left upper limb.
That shows it's a genuine one.
Yeah.
But I did not think hypercalcemia at that time. When she came for cataract surgery, then I decided, so the coin dropped. Okay, some days we learn our own mistakes.
Not sometimes, all the time.
Okay, so any other questions? Otherwise, we can stop. I think I finished my cases today. I presented 5 cases are short cases.
All cases are excellent cases, sir.
Okay, thank you. Teaching cases, no?
All
Ignore 5.
All.
The thing which I liked was that the Iglon 5 case is exactly like the one which is described in the literature. The moment he showed this grunting way, exactly like this. So hereafter, when he feels that semiology, think of this condition. Okay, then.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you. Good night.
Thank you, sir. Good night.
Thank you, good night, sir.
Good night, sir.
Good night. Good night.
Good night.
Good night. Good night, everyone. Right.